Okay, so welcome to this next video in which we are discussing bronchodilators in the treatment of asthma. Okay, so we're now turning our attention to how you treat asthma. So there are different severities of asthma, okay? So there are people who have very mild asthma, where the asthmatic attacks are very rare, basically. So if they only have them, once in a full moon, basically. And when they do have them, they're not life-threatening, okay? So you only get a weak obstruction of the airways, and they can still breathe, basically, okay? For people who have mild asthma like that, what you do is you prescribe them a short-acting beta-2 agonist. So you give them an inhaler, and basically the inhaler is not to be taken prophylactically. They don't use the inhaler all the time. Instead, they must just remember to take the inhaler around with them wherever they go. And if they have an asthmatic attack, what they do is they use the inhaler, and it will deliver through aerosol, either salbutamol or terbutaline usually, into the airways, and this will open up the airways again. So that's the usual treatment for mild asthma. Now, as it gets more severe, what happens is we start taking prophylactic measures. Okay, so if someone is likely to have asthma attacks every day, for instance, then we will start to prescribe medication that is designed to actually prevent them from getting asthma attacks. Now, the problem with this is they have to remember to take it regularly, all the time, basically. Whereas the nice thing about the initial inhaler when you have just mild asthma is that you just use it when you're actually having an acute asthmatic attack. Okay, so all the drugs we're going to discuss here are going to be, most of them are going to be prophylactics. We're going to see one drug that can be used in an acute asthma attack, okay, ipratropium, later on. Okay, so let's see these drugs that are used prophylactically then. So we'll start off with the anti-leukotrienes. Okay, so the anti-leukotrienes are going to block the cystinoid leukotrienes, and also sometimes, one of the drugs is going to block both the cystinoid leukotrienes and also the leukotriene B4. So the first two drugs we're going to start off with are going to be selective cystinoid leukotriene 1 receptor antagonists. Okay, so you remember I told you that on the surface of the smooth muscle cells there were both cystinoid leukotriene receptor 1s and also cystinoid leukotriene receptor 2s. Okay, now the cystinoid leukotrienes bind to these cystinoid leukotriene receptors on the surface of the smooth muscle cells and activate the GQ pathway. What we are now going to do is deliver drugs which will bind to the cystinoid leukotriene receptor 1 and stop the cystinoid leukotrienes from being able to bind to this receptor, and therefore stop it from being able to activate the downstream pathway. So basically we're going to use competitive antagonists for this cystinoid leukotriene receptor 1, which means a drug that will bind to the cystinoid leukotriene receptor 1, will not activate the cystinoid leukotriene receptor 1, but will stop the activation of that cystinoid leukotriene receptor 1 by the cystinoid leukotrienes. So they just bind to and block the binding of the cystinoid leukotrienes. They do not actually inhibit the receptor. They just bind and don't activate it and just stop it from being activated. So there is a subtle difference. It's not binding and inhibiting the receptor. It's binding and stopping the activation. Okay, so remember I told you that the functional significance of the cystinoid leukotriene receptor 1 and the cystinoid leukotriene receptor 2 was not really understood, but this, you might take this as sort of evidence that maybe the cystinoid leukotriene receptor 1 is more important than the cystinoid leukotriene receptor 2, because these drugs are very effective at producing bronchodilatation. Okay, or at least protecting you from undergoing bronchoconstriction. So they're very good at protecting you from having an asthmatic attack. Okay, so what drugs are cystinoid leukotriene 1 receptor antagonists? Well, there are two. Okay, there is a drug known as zafirlukast. Okay, and they both have the same suffix, okay? So zafirlukast, okay? Here, lukast is the termination of all of these names. Okay, and then there's another drug known as montelukast. Okay, so zafirlukast and montelukast will both bind to the cysteine receptor 1. They won't activate that receptor, but they will stop the cysteine from binding. Now, zafirlukast has to be taken twice a day. Okay, and it's taken orally. Whereas montelukast is slightly better, it has to be taken once a day. Okay, so montelukast is sort of taking over compared to zafirlukast simply because it's easier to get compliance with taking a drug once a day than it is to get compliance with taking a drug twice a day. Okay, so what will these drugs do? Well, you'll take them prophylactically all the time, basically, either once a day in the case of montelukast or twice a day in the case of zafirlukast. And what they will do is they will bind to these cysteine 1 receptors on the surface of your smooth muscle cells in your airways. And then if you should undergo an asthmatic attack, so if you are exposed to the allergen, then the mast cells will become activated. They'll release histamine, the cysteine leukotrienes, leukotriene B4, and also tumor necrosis factor alpha. Okay, now histamine will still trigger contraction of the smooth muscle cells, but now you won't get the contraction due to the cysteine leukotrienes because they won't be able to bind to their receptor, which is the cysteine leukotriene receptor 1. That one potentially is more important than the cysteine leukotriene receptor 2 on bronchial smooth muscle. Okay, and that will reduce the amount of contraction you get. So the asthmatic attack will be more manageable, basically. It will be hugely reduced, and they do hugely reduce the severity of the asthmatic attacks. So they're taken prophylactically, and they will be given to people with more severe asthma, basically. So where the asthmatic attacks themselves are more severe and more likely to be life-threatening, and also when the asthmatic attacks are more persistent, so you have them more often. Okay, so they are a prophylactic measure. Right, so there is another anti-leukotriene which works slightly more broadly. So this is a drug known as Xyluton. Okay, now Xyluton again is a drug that is taken orally. I should have said that these are taken orally. Okay, and Xyluton has to be taken 4 times a day. So this one's even worse, 4 times a day. Okay, and what it will do is it will go into the mast cells this time, and it will stop, and also the eosinophils, because the same process is happening within the eosinophils, but we studied it in detail in the mast cells. It will go into the mast cells, and it will block the 5-lipoxygenase enzyme. So where did we discuss this? Here we go. So it will block this enzyme, okay? So you block 5-lipoxygenase. Whoops, Xyluton is going to do this. Okay, so if you take this drug 4 times a day, then you will have you'll have very little active 5-lipoxygenase enzymes within the mast cells. So if you then are unlucky enough to get another exposure to the allergen, then what will happen is that will bind to the IgE on the surface of these mast cells, and that will try to activate the mast cells. So calcium will go up, and that will cause the degranulation of the mast cell vesicles, so histamine will be released. But as far as creating the leukotrienes is concerned, as far as creating the cysteine leukotrienes or the leukotriene B4s, it's just not going to happen. Yes, you'll produce arachidonic acid, but you won't convert it into leukotriene A4, and therefore you can't get leukotriene B4 or the cysteine leukotrienes. So, the cysteine leukotrienes aren't going to cause the bronchoconstriction, even though the histamine will still cause it, but you've reduced at least the bronchoconstriction. In addition, you have reduced the recruitment of neutrophils because you no longer have the leukotriene B4, so you've reduced the swelling as well. So that's going to help to reduce bronchoconstriction as well as the swelling, and therefore help to reduce obstruction if an asthmatic attack occurs. And I should stress that these drugs would not be given on their own. They would be given with other drugs as well, which would help to kill the asthmatic attack in other ways. So you would hopefully get absolutely no asthmatic attack. It would be reduced to very little at least. Okay. So that's how the Xoluton is going to contribute. In addition, as I said, in the late phase, the eosinophils end up producing these cysteinyl leukotrienes, and to do that, they're going to use 5-lipoxygenase enzymes within their cytoplasm. Okay, and Xoluton will go into the eosinophils as well and block the production of these cysteinyl leukotrienes by blocking the 5-lipoxygenase enzyme. Okay, so both of these drugs, zafirlukast, montelukast, as well as Xoluton, they're going to stop the production of the leukotrienes. Now, these would be the ones that you would generally refer to as the anti-leukotrienes rather than Xoluton. This is a 5-lipoxygenase inhibitor. Anti-leukotrienes means an antagonist of the leukotriene receptors. So these was what you would refer to as the anti-leukotrienes, whereas this you would refer to it really as a 5-lipoxygenase inhibitor. Okay, but I thought it was good to group the two of them together. So a 5-lipoxygenase inhibitor. And they can be used prophylactically against asthma. Okay, right. So now let's turn our attention to antihistamine drugs. Okay, so antihistamine drugs are not really used to treat asthma, but in principle they could be. Okay, they're not really used at all often in the treatment of asthma, and I'll explain the reasons for that in a moment. Okay, so why, however, would you think they would be a good idea for the treatment of asthma? Well, antihistamine drugs are competitive antagonists for H1 receptors. Okay, now I should say there are other histamine receptors. Okay, there is an H2 receptor and an H3 receptor and even an H4 receptor now. Okay, so when you say antihistamines, people know that you mean competitive antagonists for the H1 receptor. Okay, so it's taken that that is understood. You don't mean competitive antagonists for the H2 receptor or competitive antagonists for the H3 receptor. It's kind of like saying tumor necrosis factor rather than tumor necrosis factor alpha. Everyone will know what you mean, even though you could argue that it's bad terminology. Okay, so antihistamines, everyone means by that competitive antagonists for H1, not competitive antagonists for H2. If you wanted to refer to competitive antagonists for the H2, H3, H4, you would have to say in full competitive antagonists for H2, H3, H4, or whatever. Okay, so antihistamine drugs are drugs which will bind to the H1 receptor and stop the histamine from being able to bind, and therefore stop the activation of the H1 receptor by the histamine. Now, why would this be such a good idea? Well, firstly, what did histamine do? Well, firstly, it was hugely involved in contracting the smooth muscle cells that line the bronchus. Okay, so it was involved in producing the bronchoconstriction, but also it was involved in producing type 1 activation of the endothelial cells, which led to the swelling of the lamina propria. Okay, and the receptor that histamine was acting on the endothelial cells was again the H1 receptor. So if you gave an antihistamine drug, then it would stop the swelling of the lamina propria by stopping the type 1 activation of the endothelial cells, and it would also stop the bronchoconstriction, or at least reduce it hugely. So it would hugely weaken the immediate phase of the asthmatic attack. Okay, so why are these drugs not used at present? Well, actually, firstly, before we discuss that, let's talk about let's talk about different antihistamines that we could use, because antihistamines are grouped into different generations, basically. So you have what are known as first generation antihistamines. Okay, now these were the first antihistamines that ever came out. Okay, now the problem with these first generation antihistamines is that they're quite non-selective. They also have effects on the other histamine receptors. Specifically important is their effect on the H3 receptor, because the H3 receptor is in the brain, and basically when you antagonize the H3 receptor and reduce histaminergic neurotransmission within the brain, that can make you feel very tired. It produces sedation, okay? And people don't like, you know, taking a drug that makes them feel tired all the time. So first generation antihistamines have that side effect. Okay, so let me tell you the names of some first generation. Let me give you the examples of some. Okay, so a drug that's going to be important for us in a moment is clemastine, okay? Another important first generation antihistamine is promethazine. Okay, so promethazine. Another example is hydroxyzine, so promethazine. Another example is hydroxyzine. Okay, and then another example is diphenhydramine. So all of these drugs, clemastine, promethazine, hydroxyzine, and diphenhydramine. Let me move this up a little bit. Diphenhydramine. They are all first generation antihistamines. Okay, there are then the second generation antihistamines. Okay, now these have better selectivity. They are far more selective for the H1 receptor. So we adapted the first generation ones to make the second generation ones. And these second generation ones are fantastically good at just binding to the H1 receptor and only antagonizing that one. And therefore they don't antagonize the H3 receptor, not nearly to the same extent as the first generation ones do. And therefore they don't cause the tiredness that the first generation antihistamines produce. Okay, so the key example of a second generation antihistamine is the drug loratadine. Okay, and then finally there are also third generation antihistamines now, which are modified second generation antihistamines, and an example is the drug fexofenadine. Okay, so here are some examples then of antihistamine drugs. Okay, right. So, what is the problem with giving antihistamines? The problem is that if you give them orally, they don't actually have any effect on asthma. Okay, so if you give them orally, they are not useful. Now, if you give them via inhalation, they could be used as a prophylactic measure, basically. And they could be given prophylactically and taken, you know, twice a daily or something, okay, and would hopefully have a huge effect with regards to preventing an asthma attack. The problem is that if you give them by inhalation, they cause damage to the throat, okay, so they make the throat very sore, so they have side effects if you give them by inhalation. So antihistamines therefore are not generally used in the treatment of asthma at the moment. Okay, now clemastine, this first generation antihistamine, there is recent research coming out with regards to clemastine and as to whether it could be used as an inhalation medication in the prophylactic treatment of asthma. Okay, and the reason there is hope that clemastine could potentially be used like this is that it doesn't appear to cause the same level of throat soreness when delivered by inhalation as the others do. So it doesn't seem to damage the throat as much as the others. Okay, so potentially clemastine could in the future be used as an inhalation medication in prophylaxis for asthma. Okay, now another drug that can be used, okay, which I'll talk about now, is ipratropium. Okay, so this is given by inhalation. Okay, and this can occasionally be used in an emergency. So ipratropium. So ipratropium. Ipratropium is a competitive antagonist for muscarinic acetylcholine receptors. Okay, so on the surface of the bronchial smooth muscle cells, okay, you have M3 receptors. So let me draw one of these. So you have a muscarinic acetylcholine receptor, specifically the muscarinic free acetylcholine receptor. So this is a receptor for acetylcholine Now, neurons are continuously releasing acetylcholine onto bronchial smooth muscle cells, okay? And the acetylcholine binds to the M3 receptor, triggers the GQ pathway, and causes contraction of the smooth muscle cell. So, bronchial smooth muscle cells are continuously receiving a signal to contract from neurons, basically. If you give the drug ipratropium, which is a non-selective muscarinic antagonist, so there are 5 different types of muscarinic acetylcholine receptor named M1, M2, M3, M4, M5. What will happen is ipratropium will bind to the M3 receptor on the bronchial smooth muscle cells, and then will stop the acetylcholine from being able to stimulate that M3 receptor. Okay, so what will happen is these bronchial smooth muscle cells will suddenly lose this stimulation to contract that they were always receiving, and they will relax. Okay, so this can open the airways even when these bronchial smooth muscle cells are being stimulated by, let's say, histamine and cystenyl leukotrienes. Okay, so let's say that's the H1 receptor and this is the cystenyl leukotriene receptors. Okay, even when those receptors are being stimulated and causing contraction, if you suddenly remove this one that's always stimulated and always triggering contraction, you're going to hugely reduce the contraction. Okay, so this can be used to reopen up the airways in an acute asthmatic attack. So ipratropium is generally not used as a prophylactic because it has a number of side effects. Instead, it's given by inhalation when you are actually having an asthmatic attack. Okay, so if you are currently really struggling to breathe because you're having an asthmatic attack, then you can administer ipratropium via inhalation. It'll go into the airways, it'll bind to the M3 receptors on the surface of the bronchial smooth muscle cells, block acetylcholine from being able to stimulate those M3 receptors, cause the relaxation of the smooth muscle cell, and therefore help to open up the airways. Of course, it won't take down the inflammation that you've got in the lamina propria, but it will at least relax these rings of smooth muscle cells and dilatate the airways to try and open up the airways and maintain at least enough gas exchange to provide enough oxygen to the peripheral tissues that you don't die. Okay, so that's the use of these anti-leukotriene drugs, these 5 lipoxygenase inhibitors, these antihistamines, and also the muscarinic acetylcholine receptor antagonists to treat asthma.